Hotbed Talk.
Our final speaker then needs little introduction. Dr. Anna Batchellor is consultant in anaesthesia and critical care medicine in Newcastle, probably known to most of us as the past president of the Intensive Care Society and now College Council member. Anna, I heard you speak at Health Education England last week, where you talked in an animated way about healthcare practitioners, which I know has been vexing you for the last 5 or 10 years and taking a lot of your energy. I think the only thing which has stood in the way of your retirement in the last couple of years, as you tell us, is this thing called getting it right first time. So, Anna, kindly, for 20 minutes, you're going to tell us about your work.
Has anybody heard of getting it right first time? Oh, excellent. So I'm preaching to the converted, yeah? I tried to retire. I failed at retirement. So just make a plan. If you're going to retire, work out how you get out and don't get dragged back in again, because that's what happened to me. So getting it right first time started with a guy called Tim Briggs when he was president of the British Orthopaedic Association. Any of you who've met Tim will know you couldn't mistake him for anything other than an orthopaedic surgeon. It doesn't quite drag his knuckles, but close. And he's very enthusiastic, and he managed to bring his colleagues along with him. And I think that's a really important thing of what he did. So he dredged all of the data stuff, and every talk so far in this session has talked about finding data and bringing it together. And that's what Tim started to do. So the joint registry, infection figures, all of those bits of information, how many cases you get through, he brought it all together and said, we need to look at why things are done differently in different departments. And can we do things more efficiently? Can we get rid of some of the mad things that people do? So he brought together all the data that he could find, he put it into a data pack, and he turned up on the doorstep of the hospital and said, can we talk about this? And it took him a couple of years to get round everywhere, but gradually this all got some traction and people started to engage with what it was he was trying to do. So the kind of things he was looking at were really very simple things. How many joint replacements can you do in a day? If you're a good place, you can get 4 done, and if you're a kind of disorganised place, you might only be getting 2 done in a day. So, what's the difference there? How can you change that one? How long do your patients stay? That one's easy. Infection rates. In one city, he found a 10-fold variation in deep joint infection rates between different units. And if that's your knee, that's pretty important. That's kind of losing leg stuff. There's a massive variation in what implants cost in orthopaedics. If you're old, you're better having your hip replacement cemented in. It's a cheap joint. It's going to last you until you die. And it's more efficient and effective. There were loads of very expensive, fancy joints being put into people that were then having to be replaced, and not best use of things. Do you do the same operation a lot? Surgeons are more and more engaging with this idea that there is a volume-outcome relationship. And Tim was able to show if you're doing 2, 3, 4, 5 complex redo joint replacements a year, your outcomes are crap. Therefore, you should not be doing it. So you should be referring them to a place that does more, or you should have 1 or 2 members of your team who do that specific thing, and then you will result in better outcomes. This is not about your surgical ego, it is about the patients. Only an orthopaedic surgeon could have taken that message to orthopaedic surgeons, I feel. And orthopaedics is one of those things that's high up in there in costing a lot of money in litigation. It's nowhere near obstetrics. They've got the gold medal on it, but orthopaedics is pretty expensive. So he aimed to reduce variation, get everybody doing the best practice, talking among themselves, because one of the important things is he goes along and he says, this is your data. I'm not sharing this with NHS Improvement or NHS England or the commissioners or anybody else. This is your data. This is how you compare to your peers. do you want to do anything about changing it? And that is really powerful because it puts it back to clinicians. And I think maybe this kind of work, because surgeons are fundamentally competitive people. And if there's somebody down the road who's doing it better than them, they're not very keen on that. They want to be as good as everybody else. And bottom line, he showed that you could save quite a lot of money. This is kind of important to that whole thing about who you share the information with, because if NHS improvement, everybody else find out that there's money being saved, they're going to want it back again. And maybe you could be putting it into other aspects of your care. So interesting to see how that one works out. Anyway, the Department of Health was sufficiently convinced that this was a jolly fine way to move across specialties and see whether you could save money. So they've put 60 million quid so far into the whole Getting It Right First Time project, which is a lot of money. And there are lots of places that they would like to get money out of. So you will see intensive and critical care. I'm not quite sure why we've called the same thing twice, but never mind. They're hoping to get 60 million quid out of us in a year. Good luck with that one then. This very much feels to me like in 2000, your intensive care services were not able to cope with the job that you were being asked to do. So 140 million quid. Now, Monty told you that bribery works, okay? 140 million quid being put into UK, well, it was England actually, it might have been a bit Wales, critical care absolutely transformed the way we deliver our service. It brought in outreach services, it brought in networks, and it brought in high dependency units. And it was a game changer. It kind of feels like they'd like their money back now. I'm not sure where we're going to get with that bit. So, what do we do? Right, we went to ICNARC. As you heard, there's 60 million quid, so they offered ICNARC some money and said, we want your data, we want you to help you analyse all of the data. We pulled in data from everywhere we could try and find it. I'm a bit disappointed that we've kind of failed with national statistics data. And interested in what Mark was saying about kind of breaking the barriers between data sets down. A lot of the really time-consuming stuff here is trying to get access to other data systems and getting data sharing agreements and who can do what with this, that and the other. And there are so many useful things that we could be doing with data if we were all sharing it. So that's some of the data sources that we've pulled together. There are bits of information that there is no data set for. You know what you do in your place. You know what beds and doctors and nurses and everybody else you've got. So we sent questionnaires round. And with a deal of coercion, thank you very much, we got virtually all of those questionnaires back. That is pretty outstanding. And there is quite a good infrastructure around GIRFT to facilitate these things. So all of this gets pulled together in data packs. These data packs are huge. And then I troll along to your hospital and talk to you about it. Now, so far, I have done 3 pilot visits and 4 real visits. So I'm an amateur, and I'm really not sure whether I'm asking the right questions. So I'm at the... everybody's looking at me, and I'm trying to work out whether I'm doing the right thing. And I have no clue, and I guess it will come out at the end. So the kind of things that I can look at are the things that I am looking at. So we know that the distribution of beds is not even around the country. So I'm relatively lucky in the northeast. We've got quite a big deprived population. Actually, it's a very small deprived population, but it's high up on the deprivation index. And we seem to have quite a lot of beds, so I don't have to worry about them too much. Other parts of the country, a lot less beds. If you talk to any DGH, they will tell you it's really hard to get patients into neurosurgical centres, even harder to get them into a cardiothoracic centre. If you talk to the neuro and cardiothoracic people, they'll tell you what a bugger it is to get the patients back out again to a DGH. Everybody always has somebody else to whinge at, so we're trying to collect some of that data. I asked the leads for other specialties. There are 36 at the moment, I think, clinical leads for different specialties. What are the patients that you would like to get into critical care that you don't always get in? Because we all know that chest physicians will tell you that intensivists say that COPD patients will die on a ventilator and they're not having them, thank you very much. I think we've moved on a little bit from that, but there is still that feeling. If you talk to the diabetologists, they will tell you a DKA coming in with a pH less than 7 scares the living daylights out of them because they know that the acute medicine unit does not have the manpower in many cases to manage that as swiftly and as appropriately as they would like. Can you get that patient into HDU? And another one, probably even more contentious, is the gastroenterologists feel that they get a lot of pushback on alcoholic liver disease. You may have seen the publication from the Scottish Intensive Care Society last couple of weeks. Yes, patients don't do well with alcoholic liver disease that come to critical care, but 1 in 5 of them is still alive at 5 years. Is that something that we could improve if we weren't quite so negative about them in the first place? Interesting stuff. If you look in the mid-90s, people said that patients with haematological malignancies who go to critical care die. And at that time they did. That is no longer true. And we are very able to produce self-fulfilling prophecies about disease processes we don't like. So are we limiting access to critical care because of capacity or culture? I'm not sure when I'm going to answer those questions, but I'm trying. And obviously the risk-adjusted outcomes. There's other things that hospitals collect about infection and all of those bits and pieces. And we also looked at organ support days, and I'll say something about that in a minute. So you wouldn't believe how difficult it is to get cancelled surgery information. Ramani put together a massive project and come up with a whole pile of information that says we cancel a lot of elective surgery, and the Department of Health said, no, that's not true. That's because they've no clue how many operations are cancelled. From a critical care point of view, is it that your patient comes into the hospital in the morning and are told there's no bed, go home, you can't have your operation? Is it that they're phoned up the night before to be told it's really unlikely they'll get a bed, don't bother coming in? Is it that they're brought into hospital, there's no bed today, they're put in a bed and they get their operation later in the week? There's all of these multiple things and we don't count it properly. There are attempts, but it's really difficult to find out how many operations are not being done because of lack of critical care beds. So elective surgical admissions is the big growth area in critical care. If you go back 15, 20 years, we used to have 65% medical admissions averaged out over critical care units, and then there'd be some emergency surgery and about 15% of elective. We're now up to something like 30% of our bed days are taken up by elective surgical admissions. That's the big growth area. Are we taking the right patients? Are we putting them in the right level care? Do we have the right kind of units to be putting them into? Should we be looking at those level 1.5-ish? What's the magic in that perioperative phase that means that if you look after patients that little bit better, they do better in the long run? I'm hoping Ramani is going to answer that for me. That will be... Will you? You're going to try. Excellent. Thank you. So we're also looking at high acuity admissions from the ward. Is your new scoring finding you the right patients? Have you got systems in place that mean that the right patients get to you? And how many patients get resuscitated before admission? But I think I've got a massive problem because it's so easy in orthopaedics. I can count joint replacements. It's not rocket science, is it? But all of our patients are different. I've got a flipping fruit bowl here of different patients. And there are so many questions I can't answer. I've got huge amounts of data, and much of it doesn't answer the questions that I would like to be able to answer. So I end up with all of this picture of data, and you have to try and kind of go, well, what does that bit mean with that bit and that bit and that bit? And then one of the really powerful bits, or at least that's what it feels like to me at the moment, having done a few visits, is sitting in a room with the people who work in that place and finding out, are they interested in this information? Are they massively interested in the information? Who else in the hospital can be asked to turn up to this meeting to find out what the problems are and whether there's anything that's different about their place or whatever? And that is really fascinating so far. And that's what I didn't believe from Tim before, and I'm starting to see it with my own eyes. So, one of our really big problems is, what do we collect in critical care? We collect whether you're dead or alive when you leave the unit or you leave the hospital. And we really don't know very much about what happens to you after that. And that is a bit sad, really, because I can't say with too many disease processes whether you should be bringing that patient to critical care, because I can't say whether you make any difference long-term by doing it. So one of the things that we've tried to look at is, are you admitted to any hospital in England, doesn't have to be critical care, after you've had a stay in critical care? And we've looked at 1 month, 3 months and a year. And at 1 month, about 20% of patients are readmitted. At 3 months, it's about a third. And at a year, it's a half. I don't know why they're readmitted. But those are big numbers, aren't they? Is there anything that we could be doing differently at the front end that might affect some of that? Is there anything we could be doing to follow up our patients to know whether we could be doing that? And follow-up is one of the big lacks in our system. We really have absolutely no robust follow-up data on our patients. So, everybody will talk about their occupancy. They will tell you that we're 95% occupied, 105% occupied, and what seems to be the case, talking to people, is that wherever your line is on here, and there's one that's much more extreme here, right, there you go, all the way up there. At any point in the day, are you 100% occupied? And wherever that line is bears no relationship to the story that people tell me when I get there, or connected to whether they have delayed admissions or anything else. So this is about a kind of flow problem in your hospital, and it may or may not be related to your activity or anything, but it's a figure that we've kind of clung to for years, isn't it? Because it's what makes us feel like we're working hard, when you kind of go, well, Mrs. Bloggs can go in that bed, and that one can go to the medical ward, and I really don't think that means anything. So, how many of your patients are delayed? Now, so far, I haven't been to any of these. I'm quite looking forward to this, because I think I might be learning something there, but who knows? How many patients are getting CPR before they come in? Is this because you are not spotting that they're sick in your hospitals? Or is it because you're not having the conversation about, do you want to be resuscitated? And it's kind of interesting. I went to a hospital last week who said, our patients are very affluent, they're very educated, they know their rights, and they want CPR and they want to come to critical care. That might not be the way forward, and I think we might need some better educated chats. I had an interesting talk with a lady who's going to be leading the end-of-life stream for GIRFT. About care pathways and stuff. We need to be building on that. So, another bit on that about, are you getting the right people into your unit? So, how many of your patients die or do you withdraw care from in the first 8 hours after their admission? And this is going to be really interesting, tagged up with, how many of your patients come in overnight. Now, some of the patients who die within 8 hours are people that you and they really, really wanted to survive, but that wasn't possible. And some of them will be people that come in the middle of the night, and you come in the morning and go, right. And, difficult to know whether that is the case or not, but that kind of comes out in the conversations, I'm hoping. So, we've tried to look at data in a slightly different way in some cases. So this is a risk-adjusted length of stay. Traditionally, if you ask people why their patients stay in ITU for a week compared to everybody else where it's 5 days, they will say, we've really deprived, sicker patients, blah, blah, blah. So this is trying to risk-adjust them and see whether your length of stay, how it varies compared to everybody else. That's going to be some interesting conversations, I think. Now, I'd love someone to tell me what the hell this means, because I have no clue. So, if you put a diagnosis of pneumonia as your reason for the patient coming into the unit in your whatever data thing you put your ICNARC data into, then how many days of advanced respiratory, cardiovascular and renal support do you give those patients that you have said have pneumonia? Okay, so this is one unit. This is another unit. And this is yet another. Are they all treating the same thing? Are two of them doing it wrong and one of them's doing it right? Are they all doing it wrong? I have no clue what it means. I mean, it's quite fascinating, isn't it? And if anybody'd like to tell me over lunch what the hell I'm looking at there, I will be very pleased. But I have a horrible feeling I'm going to end up with more data than I know what to do with, and quite difficult to tell what it really means. So, is there something about the number of days you, I'll try and hurry up, supply advanced respiratory care to people? Is there a volume outcome effect that we should be addressing in critical care? I said earlier that surgeons are coming to terms with the fact if you don't do something frequently, you're probably not so good at it. And this is a whole team. If your whole team looks after a lot of people with bad lungs, you're probably not too bad at it, we hope. If you don't do it very often, you might not have got all those little wrinkles. So if you're down here, should you actually be doing it, or should you admit that maybe you should be transferring your patients? Those might be some interesting conversations, especially if they're related to the fact that you're now 50 miles away from another unit. And do you accept less good outcome for access? Who knows? So this is a measure that we decided to look for along with the renal team. It certainly happens in my units. Patients who come in acute renal failure, single organ, and you are unable to transfer them to a renal unit, so you filter them in your unit because somebody has to do something. And the renal people actually get the budget for this, you'd be interested to know, in most of England, but they don't deliver it in lots of places. So that one's going to be quite interesting, because they know that they're not delivering it, so they want that information too. So what does this mean? So this is our standard, are we doing well or not well, picture that we all look at when our reports come back from ICNARC. What's my SMR? Am I really clever at this job? Because you would not be surprised to hear that every brownie points form that I've ever read from a critical care clinician tells the committee how wonderful their SMR is, and it's in the top 10% of the country. So this one, which is kind of getting perilously close to falling outside the 2 standard deviations, was from a unit that absolutely everything else felt really good when I sat down and talked to them. They were getting patients in quickly, they were doing all of the right things, but their SMR's bad. So is it that they're rubbish at this, or is it that they're rubbish at coding? And I do wonder whether there's a lot of... So they were going back to look at this. Actually, what I would worry about in this is if there are some people who will say to me, but we're within 2 standard deviations, so what does it matter? That's just statistics. And this is true, but if that was mine, I'd want to go back and work out whether that was right and whether I should be doing something to change that. So anyway, it's a bit of an attitude thing. So... it's not just a case of going along, looking at what people do, having a chat, producing a report and saying, there you go. There is a whole implementation side of the system, which is answering to the GIRFT programme, which is run from the Royal National Orthopaedic Hospital at Stanmore, with their 60 million quid, and is not allied to NHS England or NHS Improvements, or anybody else that I can see, who are the implementation side of this. So taking what's in the reports and going back to the trusts and saying, OK, how can we change this? How can we make it better? So far, reports have been published in orthopaedics, general surgery, vascular surgery. They're very keen to push networks there. That's fine. Will they move the critical care beds with the networks? I don't know. Cranial neurosurgery, there's a whole stream of them coming out. All the medical reports are going to take quite a while because most people are a bit like me, kind of struggling with what does the data mean. Thank you very much for listening.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.